Hi, my name is Elliot Israel. I'm professor of medicine at Harvard Medical School, and I'm a member of the Pulmonary and Critical Care Divisions and the Allergy and Immunology Division at the Brigham and Women's Hospital. And I am part of the Partners Asthma Center and head up with my co-director, Chris Fanta, the Brigham and Women's Hospital Severe Asthma Center. I'm going to be talking about asthma treatment, including asthma exacerbations. I disclosed the following relationships in the past year. I'm going to be talking about asthma treatment. I'm going to be talking about understanding control. Then I'm going to be talking about therapy, including new therapy and controversies and some modalities that we use to follow asthma. I'm also going to be talking about approaches to subcategories of asthma that you see, such as exercise and aspirin and exacerbated respiratory disease. I'm going to be talking about difficult to control asthma and the at-risk asthmatic. And then I'm going to be talking about asthma exacerbations and how we treat those. So when we talk about asthma severity and control, there are two domains. One is the impairment domain, and that impairment domain relates to frequency and intensity of symptoms and functional limitations. And in terms of symptoms, we think about nighttime symptoms, need for beta agonists, missing school or work, ability to engage in normal activities, quality of life assessments. And then we think about impairment in terms of lung function or physiology, which we measure by spirometry or peak flow. In addition to the impairment domain, we also worry about asthma, which is a variable disease, and we worry about risk. The likelihood of asthma exacerbations, the likelihood of a progressive decline in lung function, or a risk of adverse effects from medications. And we assess the risk domain primarily by the frequency and severity of exacerbations, the need to use oral corticosteroids, urgent care visits, obviously hospitalizations as well. And the goal of asthma therapy, which we're going to talk a little bit about, is to reduce the impairment and to reduce the risk. And the impairment, we talked about the troublesome symptoms, the beta agonist use, maintaining activity, and the risk, we talked about recurrent exacerbations and decreasing the effects, the side effects of medications. And I'm going to talk about something which I call the rule of twos in terms of trying to maintain asthma control. And this both includes the impairment and the risk domain and the symptom domain. So we basically say that people are well controlled or people are not well controlled if they have nighttime awakenings more than 2 times a month, if they're using the short-acting beta agonists more than 2 days a week, if they're having symptoms more than 2 times a week, if their measurements instruments, in this case one is known as the ACT, has an ACT less than 20, if their lung function is reduced by greater than 20%, so that their lung function isn't 80% predicted or more, and if they're having more than 2 exacerbations a year. So this is what I call the rule of twos. Basically, are you waking up 2 times a month? Are you using beta agonists more than 2 days a week? Are you having symptoms more than 2 days a week? Is your ACT less than 20? Is your lung function reduced by more than 20%? And you're having 2 or more exacerbations a year. While we're going to talk about this, I just want to pre-shadow or foreshadow for you what we're going to talk about in terms of a stepwise approach to asthma therapy. If you have intermittent asthma and don't exceed the rule of twos, then you're just going to be using short-acting beta agonists. But if we start increasing, or patients have persistent symptoms, we talk about starting basically low-dose inhaled corticosteroids with the possibility of using a leukotriene antagonist, especially in children. If they're still not well controlled, moving up to medium-dose inhaled corticosteroids or considering a low-dose inhaled corticosteroid plus a long-acting beta agonist. If they're still not well controlled, moving up, if they were on medium-dose inhaled corticosteroids to medium-dose inhaled corticosteroids plus a LABA. And then if they're still not well controlled, moving up to a high-dose inhaled corticosteroid plus a LABA. And if they're still not well controlled, consider adding tiotropium and considering omalizumab. And if they're still not well controlled, considering oral corticosteroids, omalizumab for patients who have allergies, and as we'll talk about, anti-IL-5 therapy, anti-interleukin therapy. And at the same time, we're stepping up if patients are not well controlled, and we are stepping down. We're assessing control when we see patients, and we're stepping down if possible, and assuming if the asthma has been well controlled in the previous several months. And I mentioned the asthma control test. I said if your asthma control test is less than 20, then you're assumed not to be well controlled. This is an easy to administer test that can be used in the office. It has 5 questions and basically asks about how people have been doing in the past 4 weeks, how much time they've spent how much they'd been kept out of school, how often they'd had shortness of breath, how often they'd had symptoms of chest tightness, how often they'd had to use their inhaler, and how they would rate their asthma control. And completely controlled is 5s, and so you can have a maximum 25. And if you're below 20, you're considered poorly controlled, and that's an indication to explore why somebody might not be well controlled, and if there aren't environmental issues that you can fix, considering intensifying pharmacotherapy. And as I mentioned, so control on the asthma control test is 20 or more. There's an alternative test known as the asthma control questionnaire. You're considered well controlled if you're 1 or less, and a 0.5 change is felt to be enough to make a change in therapy. So if people who have a 1.5 or greater are thought to be people who would benefit from control. And then I wanted to review the medications we have. You're probably all familiar with the short-acting beta agonists. They're the most effective medications for relief of acute bronchospasm. As we mentioned with the rule of 2s, when you're using them more than 2 times a week, other than before exercise, it suggests inadequate control. Previously, patients were told to use these regularly. The data really suggests that regular use is not generally recommended. It lowers effectiveness, it can increase area responsiveness, and it can be particularly problematic for some people with genetic variants, such as an arginine variant, the 16th amino acid position of the beta agonist receptor. And so we tell patients to use these medications when they need them, rather than using them on a regular basis. Inhaled corticosteroids are in the category of what we call controller medications, and they're the most effective controller medications. We use them with a spacer to reduce local side effects such as thrush and dysphonia. And long-term, very high doses are associated with a small increase in osteoporosis, cataracts, glaucoma, and you can see dermal thinning, especially in the elderly. But remember, these are really high doses. There's no question that these should be used instead of having patients have to use multiple courses of oral corticosteroids, where these effects are front and center. They've been shown you can use inhaled corticosteroids as needed with symptoms, and that's been shown to be as effective as regular use in patients with mild persistent asthma. As needed use in combination with a quick onset long-acting beta agonist on top of regular twice-a-day long-acting beta agonist inhaled corticosteroid use appears to provide good symptom control, but is not approved in the USA and is actively discouraged by the FDA because of its concern about long-acting beta agonists, although some of that may be modified, as I'll talk to you in a little bit. When we think about inhaled corticosteroids, there are multiple inhaled corticosteroid formulations on the market. I've listed the common ones that are available, and these come usually in multiple dose ranges, and you can have patients take different doses, right? So you can have patients take 2 puffs twice a day, 4 puffs twice a day, 1 puff twice a day. And so the issue of when I went through the overview of the medications, are you on low dose, medium dose, and high dose? And they differ for each of these. And so the problem for a practitioner is, well, how do you really figure this out? And the bottom line is generally 4 puffs twice a day of the highest dose formulation equals high dose medication. So you can see, for instance, in flunisolide, 8 puffs a day of the 500 microgram formulation is 2,000 micrograms. In addition to the inhaled corticosteroids, we have the long-acting beta agonists. We do not use them alone for asthma. When used alone in asthma, they can increase the risk of serious exacerbations. They are not a substitute for anti-inflammatory therapy, and they're not appropriate for monotherapy in asthma. There is a black box in that regard. However, there was also a black box on all the inhaled corticosteroid LABA combinations, and that, as I'll talk about it, that black box has been removed. These medications are not for acute symptoms or exacerbations because they don't, in most cases, provide immediate relief. However, LABA combined with inhaled corticosteroids are very effective medications. They decrease symptoms in patients who are on moderate to high-dose inhaled corticosteroids still have symptoms. And the concern has been that they might increase the risk of severe exacerbations and deaths, especially in blacks. Due to the above, the FDA had suggested that patients controlled on combination therapy actually undergo an attempt to have their LABA eliminated after they achieve control. However, there were several mandated studies done by the pharmaceutical companies that produce ICS-LABA, and those studies showed that there was no increase in serious exacerbations when you added a long-acting beta agonist to inhaled corticosteroids, as opposed to adding the inhaled as opposed to just using the inhaled corticosteroid alone. So the FDA has removed the black box from the LABA inhaled corticosteroid combinations, saying that they do not represent a risk of increased untoward effects that could be detected by these studies. However, use of a long-acting beta agonist alone without inhaled corticosteroids in asthma, as opposed to COPD, is still not recommended. In addition to what we used to call the long-acting beta agonists, which were used twice a day, we have super long-acting beta agonist combinations. These are now 24-hour long-acting beta agonist combinations. There's a combination of fluticasone furoate, 100 with vilanterol. So this is a long-acting inhaled corticosteroid and a long-acting beta agonist, and it comes in a 125 and a 225, combines the inhaled corticosteroid and the long-acting beta agonist. These are only approved in 18-year-olds and above. 1 puff of the lower dose equals 1 puff of the medium dose inhaled corticosteroid, and 1 puff of the 225 is equivalent to high dose inhaled corticosteroid used twice a day. High dose inhaled corticosteroid LABA used twice a day. We also have leukotriene modifiers. As you remember, they block the production or the action of leukotrienes, and they're particularly indicated in aspirin-induced asthma or aspirin-exacerbated respiratory disease, as it's known now. They're also indicated in exercise-induced asthma because they produce equal or better long-term protection than long-acting beta agonists. They're also an alternative in the guidelines to adding inhaled corticosteroid or LABA, and they're add-on therapy in severe asthma. There had been, when they were first introduced, some question of Churg-Strauss syndrome or eosinophilic angiitis when steroids were tapered, but that's not become an issue anymore. And when we think about therapies and interventions of therapies, we should also think about difficult to control and severe asthma. Asthma that's uncontrolled or difficult to control is thought to be asthma that remains uncontrolled despite or requires high-dose inhaled corticosteroids and a LABA, and it still is uncontrolled. And if the comorbidities, because there could be reasons that people have uncontrolled asthma that might not be just related to severe asthma, they might be related to reflux or sinusitis. But if the comorbidities have been addressed, we call that severe asthma. But functionally, basically, we can think about difficult to control asthma. So just to kind of put this all together in terms of how we think about escalating patients. So remember, we think about the rule of twos and whether patients are controlled or not controlled. And if patients are not controlled, we escalate them starting with preferentially low-dose inhaled corticosteroid, although in kids we might consider leukotriene antagonist if we're worried about inhaled corticosteroids. If still not well controlled, use a medium-dose inhaled corticosteroids, or alternatively, a low-dose inhaled corticosteroids plus a long-acting beta agonist. Again, the black box has been removed. If they're still not well controlled, we consider medium-dose inhaled corticosteroids plus a long-acting beta agonist. If they're still not well controlled, we consider a high-dose inhaled corticosteroid. And if they're still not well controlled, we consider adding tiotropium, and we consider omalizumab, anti-IgE, which we'll talk about in a minute, or we consider anti-IL-5 for those with exacerbations and eosinophils greater than 300. I mentioned that in patients who are poorly controlled despite inhaled corticosteroids and a LABA, that we consider adding tiotropium. And I'm just showing you some data from the New England Journal where they looked at adding tiotropium versus doubling the dose of inhaled corticosteroid or adding salmeterol, and they showed that adding tiotropium was as beneficial as adding salmeterol, and another study where that was used as add-on therapy. Another concept that I think is important for you to understand, and we'll be talking about this, is we now have a new concept of the inflammation of asthma, and we talk now about type 2 inflammation and non-type 2 inflammation. And what do we mean by type 2 inflammation? We think about type 2 inflammation as being inflammation that's so-called allergic. And in that regard, we think about it as inflammation in which there's either overproduction of IgE and or involvement of eosinophils. And most commonly, that occurs with antigen exposure. And in this case, we're showing the different pathways where there are different cytokines that are involved in either production of IgE or maturation of eosinophils. And the reason I'm showing you this is that there are cytokines that are being targeted in our new therapeutic approaches. So when we think about type 2 inflammation, we think about inflammation with the involvement of three primary cytokines: IL-4, IL-5, and IL-13. Interleukin-4, interleukin-5, and interleukin-13. Interleukin-13 is primarily involved in promoting production of IgE. Interleukin-5 is primarily involved in promoting eosinophils, and interleukin-13 is involved in increasing airway smooth muscle, contractility, and mucus hypersecretion, and these are frequently released in the context of antigen exposure. They can be stimulated by non-antigenic exposures, but we call these type 2 because they're produced by type 2 cells, IL-4, 5, and 13. Then we think about non-type 2 inflammation related to irritants, pollutants, microbes, and viruses, which can also set off asthma. In some respects, these can cross over and cause type 2 inflammation, but frequently these involve neutrophils. They involve types Th17 cells, and interleukin-6 and interleukin-8 and interferon may be more important in this non-type 2 inflammation. And the reason we are dividing things into type 2 and non-type 2 inflammation is that there now are several new interventions on the market which particularly target type 2 inflammation, and some that are being developed that target other parts of type 2 inflammation. So it's important for you to understand that and thinking about new developments in asthma and precision medicine in terms of who we target. So having said that, let me talk about some of the biologics. So one of the biologics that has been available for now almost 10 years or more is anti-IgE, omalizumab. And anti-IgE is used for poor control in patients on high-dose inhaled corticosteroid or LABA, or equivalent to what we call step 5 therapy in that diagram that you're showing me. And this targets the IgE portion of the cascade of production of inflammation in these types of asthmatics. The qualifications for being treated with anti-IgE is you have to have it in the United States, is you have to have an IgE of 30 to 700, and you have to have a positive skin test or a RAS, that radioabsorbent allergen test, to inhaled perennial allergen. And in patients who are poorly controlled on high-dose inhaled corticosteroid and LABA, and who have an IgE and a positive RAS or skin test, this drug reduces exacerbations by a quarter to half. There's a small improvement in airway function, which is really minimal, and obviously not all patients respond. This therapy is available. It's administered in the office either every 2 weeks or every month. And there is rare anaphylaxis, although patients do need to stay in the office for half an hour after administration of this anti-IgE. In a new set of therapies that have recently become available are therapies that target interleukin-5. And there are two types. There's a direct anti-IL-5 and there's an anti-IL-5 receptor. These drugs have recently been approved: mepolizumab, reslizumab, and benralizumab. Mepolizumab and reslizumab target the circulating anti-IL-5. Benralizumab targets the anti-IL-5 receptor and results in eosinophil death as a result of targeting the receptor. But all of them fairly rapidly reduce eosinophils. They have been shown to reduce exacerbations in patients with 2 or more exacerbations per year who have high blood eosinophils. And so basically, the current recommendations for most of this is to use these in patients with persistent exacerbations, usually at least 2 exacerbations, despite compliance with the high-dose inhaled corticosteroid LABA, and a history of blood eosinophils, generally measured by eosinophil counts on the complete blood count of greater than 300. So a relatively easy available test is a CBC with a differential and an absolute blood count of greater than 300 with a history of persistent exacerbations has been shown to produce a decrease in exacerbations. And this is a composite slide showing the effect of mepolizumab and modeling the green line here being patients with 2 exacerbations, patients with 3 exacerbations, patients with 4 exacerbations, and the the x-axis here being the baseline eosinophil count, and so this is a 300 count. And this is the number of clinically significant exacerbations, and these lines are the patients treated with the drug versus the patients treated with placebo. And you can see that with greater number of exacerbations, clearly with an eosinophil count of 300 or greater, you get a very significant reduction. As you get to 2 or more exacerbations, only patients with higher eosinophil counts really get a significant reduction in exacerbations. And so that's why the general thought is patients with 2 to 3 exacerbations in a year with at least a medium level of eosinophils of 300 or more are patients that you could target for that. In addition to these exciting biologic therapies, there has been a procedure introduced in the past 4 to 5 years called bronchial thermoplasty, where patients undergo 3 bronchoscopies, and there's radiofrequency ablation of the smooth muscle. It's been shown to reduce symptoms and reduce asthma exacerbations when you count those exacerbations after bronchoscopy. There's a significant upfront morbidity. Patients can end up with asthma exacerbations from these bronchs, sometimes hospitalized. The Severe Asthma Task Force recommends that bronchial thermoplasty only be performed in the context of a clinical trial or a registry at this point. I want to talk a little bit about therapies not yet approved, because I mentioned to you the type 2 cytokines, and I mentioned IL-4, 5, and 13. I showed you drugs that target anti-IL-5. There is a drug called dupilumab, which targets IL-4 and 13 because the IL-4 and IL-13 receptors share a common component. This drug is approved for atopic dermatitis and is in late phase testing for asthma. The studies show that it improves lung function, it reduces exacerbations, and is very effective to treat atopic dermatitis. The limit of eosinophils for this drug isn't quite as clear yet, and this drug, as opposed to others, can lead it to an increase in eosinophils, temporarily at least, as opposed to the others, which dramatically reduce the eosinophils, but it does produce a positive effect. And this drug, as opposed to the others, lowers exhaled nitric oxide, and I'll talk a little bit about exhaled nitric oxide. I also want to talk about, to be complete about therapy, recommendations regarding allergen immunotherapy. So what do you do for asthmatics, and when do you consider allergen immunotherapy? You consider allergen immunotherapy for asthmatic patients when there's a clear relationship between the symptoms and unavoidable exposure. So the veterinarian who has a cat allergy, the person who in their occupation does something, or the person who, for social reasons, can't get rid of an animal or change their environment. Consider it when symptoms are prolonged or perennial. It's a little less clear in terms of very focused, just spring exacerbations. And you also consider it when pharmacotherapy is difficult or expensive because medication's ineffective, because multiple medications are required. The patient doesn't want to use the medications. And the other place where it's helpful is when patients have a strong rhinitis component, because allergen immunotherapy is extremely effective in rhinitis. So to review the therapies. Again, remember the rule of 2s. If you're waking up more than 2 times a month, if you're having symptoms or needing your beta agonist more than 2 days a week, if you're having more than 2 exacerbations a year, if your lung function is reduced more than 20%, we think that you're not well controlled, and we move up. Low dose inhaled corticosteroids, medium dose inhaled corticosteroids, or medium dose inhaled corticosteroids, or low dose plus a LABA, medium dose inhaled corticosteroids plus a LABA, high dose inhaled corticosteroids. At this point, you consider adding tiotropium, and if they're still not well controlled, consider anti-IL-5 therapy. Remember, you move up and you move down, and at each point, although we're talking about pharmacotherapy, you want to talk about environmental control, and patient education. I said I would talk about some subcategories of asthma, so exercise-induced bronchospasm, and so patients can be fairly well controlled, say, I'm not having problems, but I like to run, and I really can't. What are you going to do for me? What can be done? So obviously, patients can use short-acting inhaled beta agonists shortly before exercise. That effect will last for 2 to 3 hours. Salmeterol, or the long-acting beta agonist, so formoterol as well, can prevent exercise-induced bronchospasm for 10 to 12 hours. The problem is if somebody's a regular exerciser and using these regularly, there's a 50% or greater tachyphylaxis with greater use. So patients will come in and say, this worked well for me for the first week or so, but now I'm finding that before I could run for 2 miles, now I can only run a mile, and what should I do? Leukotriene modifiers can be effective. They provide long-acting inhibition, and so they can be effective in this case. Cromolyn and Docromol are also effective, although their availability has become scarce. Other things that can be done is a lengthy warm-up period before exercise can preclude medications for patients who can tolerate it. And you want to be sure that the underlying asthma is well controlled. So a patient whose asthma is not well controlled is going to have problems with exercise, and doing these things is not going to fix that. You need to fix the underlying asthma to get good control. What about aspirin-exacerbated respiratory disease? We used to think about this as an allergy to aspirin, but it's not an allergy. It's actually a sensitivity to anything that blocks cyclooxygenase 1, so non-steroidal anti-inflammatory drugs and aspirin, and it's characterized by leukotriene overproduction in response to these drugs. It appears to be related to downregulation of prostaglandin E2, which provides a brake for leukotriene production. It's most common in patients with rhinosinusitis. It's pretty rare in kids. It usually occurs in adults. And the prevalence is 5 to 25%, with increased prevalence in more severe asthma. Leukotriene modifiers, antagonists or inhibitors, are a critical component of treatment of these patients since they affect leukotriene-mediated effects. You want to treat the rhinosinusitis aggressively. If patients need to use pain relievers, they can use acetaminophen, or specific COX-2 inhibitors are generally safe in moderate doses, but when you get to high doses, they can bleed over and cause an aspirin-induced reaction. And acetaminophen is safe in most patients, although there are some patients, there's a very, very, very little bit of COX inhibition by acetaminophen, which obviously is a little bit more pronounced at high doses, and some patients may be so sensitive that they can even react to acetaminophen. I mentioned exhaled nitric oxide. I mentioned that the new dupilumab anti-IL-4/13 therapy reduces nitric oxide, and many of you may have asked what is nitric oxide and what is it doing? Nitric oxide generally reflects ongoing eosinophilic inflammation in the airways. It can be measured in an office visit if you have the equipment. Generally, a level of greater than 30 parts per billion is consistent with persistent eosinophilic inflammation. It is markedly reduced by the use of inhaled corticosteroids. So if you have a patient on inhaled corticosteroids and they don't have a high nitric oxide, it doesn't mean that they didn't have any eosinophilic inflammation. It just means that nitric oxide has been suppressed by the inhaled corticosteroids. When can it be useful? Well, it can be useful in evaluating a new patient with asthma who comes in, if you want to understand whether there's type 2 or eosinophilic inflammation. The other time it can be useful is persistently high exhaled nitric oxide, despite therapy, is either a sign that somebody's non-adherent or that they have a pathobiology that's resistant to the therapies they're currently on. It can be maybe a good predictor for response to therapy for patients considered for biologics aimed at type 2 therapy. So the anti-IgEs, the IL-5s, the IL-4/13, and if you see patients with high nitric oxide despite therapy and you think they're complying, or you can document their compliance or adherence, you might consider initiation of the biologics. And in that case, we'll tend to use a lower threshold, even patients with an FeNO greater than 20. So if we're talking about using biologics and talking about asthma severity, so what makes asthma difficult to control? There are different pieces of this. 50% of patients who are poorly controlled generally have poor adherence or technique, so it's important to think about examining that. Uncontrolled rhinitis and sinusitis can be a problem, and up to 50% of patients can have sinusitis and not know it. Gastroesophageal reflux had been thought to be a major contributor. That's recently been questioned in several studies, and certainly in patients who are not symptomatic with reflux, it's unlikely that reflux will be associated. In some cases, drugs such as nonsteroidals, of what we've talked about, but every once in a while we'll pick up patients who are either on a beta blocker whose asthma's gotten worse or are using beta blocker eye drops. Another thing is environmental allergens, so the patient who's living at home with multiple dogs or cats and has high dog or cat allergy, or goes to work and there's been flooding and there's mold. There's occupational exposures such as Baker's asthma, and sulfite sensitivity, which is less of a problem now that people are really into that. What's the differential diagnosis of persistent, poorly responsive wheezing? I think there are some things that we need to think about. The first and most common really is the bottom here. In your older patient population is congestive heart failure, which can produce wheezing, even sometimes obstruction on PFTs. For severe and poorly controlled asthma, vocal cord dysfunction is sometimes a problem, and that can sometimes be detected by flattening of the flow volume loop. When you look at a fiber optic exam and have these patients expire, there's chinking of the vocal cords on the fiber optic exam. It occurs in depressed patients frequently. It's almost always not just in patients who don't have any asthma. There's always some degree of airway hyperresponsiveness. In children, one needs to think about central airway obstruction, and even in adults, a mass or sometimes with connective tissue disease, collapsible airways. One needs to think about an aspirated foreign body. In some of the autoimmune diseases, such as rheumatoid arthritis or ulcerative colitis, you can get a constrictive bronchiolitis, which produces decreased airway function. Bronchiectasis, associated with sputum production and abnormal airways on CT, is something you can consider as well. And this just shows you the vocal cord dysfunction, what the airways look like, and this is the anterior and posterior, and here you have chinking, so abnormal closure of the vocal cords with inspiration or expiration. I'd like to now move on to treatment of exacerbations. And so the principles of care for acute asthma, the principal goal is rapid reversal of airflow obstruction. That's the major problem, airflow obstruction either through airway constriction and or mucus plugging. And so one of the major things is a repetitive administration of inhaled beta agonists, plus or minus ipratropium bromide. The data suggests that early addition of systemic corticosteroids, oral corticosteroids, early in the beginning of the episode is helpful. Correction of hypoxemia if occurs is important. And if you're treating patients with acute asthma, you want to monitor them closely to be sure that they're moving in the right direction and that they're not going toward respiratory failure. And so how do you assess the patient? Obviously, history of what's been happening, physical exam, looking at things like accessory muscle function, ability to complete sentences, peak flow determination, a chest x-ray or arterial blood gases can be useful ancillary things for evaluation. In terms of the emergency room management, the standard is to give inhaled bronchodilators every 20 minutes. Nebulized and high-dose, meter-dose inhaler are equivalent in adults. So you can have patients take 8 puffs of a beta agonist every 20 minutes if you don't have access to a nebulizer. We give prednisone 60 milligrams to patients who do not respond rapidly and fully to inhaled bronchodilators. At discharge, the general good practice is to give patients a 7-day course of prednisone together with inhaled corticosteroids for patients who have less than maximal lung function. In cases of recalcitrant asthma with recurrent emergency room exacerbations, we consider intramuscular corticosteroids, and that can be triamcinolone 80 milligrams as an alternative in non-adherent patients. And all patients should receive inhaled corticosteroids on need to discharge. If you've had to come to the emergency room for your asthma, you at least for a period of time should be using inhaled corticosteroids. And if you have recurrent visits, obviously should be using them all the time. What about antibiotics for acute severe asthma? So patients come in with an asthma exacerbation. They frequently have purulent appearing sputum, but it really often contains eosinophils rather than neutrophils. And so the studies during attacks show that transtracheal aspirates show no greater prevalence of bacterial pathogens than among controls without respiratory disease. So empiric antibiotics have no proven benefit in hospitalized patients with acute attacks, and we generally don't administer antibiotics unless there's proof of an infection. What about helium-oxygen mixture known as heliox? And so this is mixing oxygen with helium. And why does this potentially work? Because it reduces a low-density gas has reduced turbulent flow, and there's a lot of turbulent flow in an asthma exacerbation, and it can provide a better vehicle for delivery of inhaled bronchodilators. There was a meta-analysis now in 2004 that felt the existing evidence does not provide support for the administration of helium-oxygen ministers to ED patients with moderate severe asthma. And they felt that heliox didn't have a role in the initial treatments of acute exacerbations. They admitted that this should be interpreted with caution. Certainly in patients who are doing poorly and deteriorating, this might be a consideration. We certainly have seen patients where this definitely decreased the work of breathing, and so it's considered as well. Intravenous magnesium or inhaled magnesium, the results of this have been heterogeneous. There's limited positive evidence in adults, but it's quite popular in emergency room visits. In emergency rooms, there's an apparent reduction in hospitalizations and improved pulmonary function in children with severe asthma. That's been taken to be used in adults as well, and so it's widely used in emergency rooms. How about unconventional therapies in acute severe asthma? Non-invasive mask ventilation, that's used when patients are beginning to deteriorate and are tiring, and sometimes can be used to bridge them, although frequently that may not work. In patients who are in extremis, intravenous ketamine has a direct smooth muscle relaxation component. Sometimes you can use anesthetic agents. And in patients who are intubated, we sometimes use whole lung lavage to try to clear the mucus plugs. And in some cases where oxygenation is a real problem, we'll use ECMO, extracorporeal membrane oxygenation. This is basically attaching a patient to a machine which basically oxygenates the blood and removes CO2 when the lungs are not working. This is really a therapy for when you think you're bridging somebody and are going to pull them out and they just need more time. When do we think about in-hospital treatment? When we need to remove somebody from the home work environment, when they really can't exert themselves, when we want to assure medical compliance, and when we want to do close observation deterioration and figuring out what the severity of an asthma exacerbation. When do we consider intubation, mechanical ventilation? Obviously, respiratory arrest and agonal respirations. But if patients are doing poorly, if there's evidence that they're tiring, and so a PCO2 of greater than 55, a pH less than 728 have generally been interpreted as times we do this. In patients who are in respiratory distress, whose PCO2 is rising despite aggressive therapy, and who cannot or will not cooperate with other therapies, so they can't tolerate a mask for non-invasive ventilation, or they're getting agitated, and we're concerned that these are premonitory signs for an eventual respiratory failure. What do we do when we put these patients on ventilators? These patients are notoriously difficult to ventilate because they have airway obstruction, and we're trying to force air into their lungs. There can be very high pressures as one tries to do normal ventilation. And so we adopt in these patients what's called permissive hypercapnia. So while you know that a normal partial pressure of carbon dioxide is about 40, and in many cases we will target that for ventilatory issues other than asthma. In asthma, we will allow decreased flows on the inspiratory phase to decrease the pressures while trying to prolong the expiratory phase to allow emptying. And therefore we will allow the partial pressure of carbon dioxide to go up high. So we will take these patients up to PCO2s of 60 and 70, and if necessary, adjust the pH, in some cases even using bicarbonate if necessary, if the pressures are too high, if it's very difficult to mechanically ventilate. And the idea is that we want to try to give as much time for expiration, because what happens is with these patients being very constricted, their airways constricted, we're pushing air in, and the problem then is that air can't get out. We sometimes use paralysis in these patients to try to relax the muscles, and there is a concern about paralysis in patients because there's a interaction between the paralytic agents and corticosteroids, which can sometimes cause a myopathy. Sometimes we'll use Heliox, and which remember is the helium-oxygen mixture, can sometimes reduce the resistance to flow. And in some cases we'll consider bronchoscopy and lavage to remove the mucus plugs. When can we discharge patients from the ICU or the hospital? They obviously have to have resolution of their severe shortness of breath, wheezing, and cough. We generally say that their lung function needs to be improved by 50% at least 50% over the initial value of presentation. We want their peak flow to be 60% of normal or at baseline in low-risk patients, and at least 70% of normal in high-risk patients. And what do I mean by high-risk patients? So which patients are at high risk for extreme morbidity from asthma, from either getting intubated or dying or ending up in the hospital? So the profile is patients who have newly diagnosed asthma, patients who are on daily prednisone prior to admission, patients who've had 2 or more ED visits in the last 6 months, patients who've had 1 or more hospitalizations in the last year, a patient who's ever been intubated, or patients who have severe psychosocial problems such as depression or schizophrenia. These patients are all at high risk for morbidity from asthma. So what are the points to remember? The rule of 2s for severity and step-ups. Remember symptoms more than 2 times a month, using your beta agonists or having symptoms more than 2 days a week, having more than 2 exacerbations a year, an FEV1 or peak flow less than 20%, an asthma control test score of less than 20. Remember the steps of 1 to 6. I think now it's worthwhile thinking about type 2 or allergic type inflammation, IgE and eosinophils, and the anti-IL-5 therapies. Aspirin exacerbated respiratory disease, and you should think about that in patients with nasal polyps. Think about aggravating factors that might make asthma worse. Think about the differential diagnosis, especially congestive heart failure. Think about vocal cord dysfunction, and in terms of thinking about the acute ICU management, permissive hypercapnia for respiratory failure. So questions for review. So which of the following is not indicative of poor asthma control? A, as-needed asthma reliever medication 3 times a week. B, reliever medication used pre-exercise 4 times a week. Nighttime awakening 3 times a month. 3 exacerbations per year. And the answer is B. Use of bronchodilators pre-exercise is not considered an index of poor control. All the others exceed the threshold for control, which in this case is no more than 2 times. Remember the rule of 2s. So using your beta agonist for exercise doesn't mean you're poorly controlled, but using it more than twice a week, 2 days a week, or waking up more than 2 times a month, or having more than 2 exacerbations is an indication of poor control. Question number 2. Which of the following is not required for consideration for anti-IgE therapy? An IgE greater than 30, allergic rhinitis, a positive skin test or RAST, a poor response to level 5 therapy. And the answer is allergic rhinitis is not required to be on anti-IgE therapy. You do have to have an IgE greater than 30. You do have to have a positive skin test or RAST, and remember it needs to be to a inhaled perennial allergen. And in order to consider this therapy, you should have failed high-dose corticosteroids and a LABA, which is step 5 therapy. Question number 3, which of the following is not associated with high-risk asthma? More than 2 ED visits in the last 6 months, 1 or more hospitalizations in the last 12 months, ever intubated for asthma, vocal cord dysfunction, severe psychosocial problems. And the answer is D, vocal cord dysfunction is not independently associated with high-risk asthma. Vocal cord dysfunction can make asthma appear difficult to control, but it does not increase the risk of death or hospitalization unless it's associated with severe psychosocial problems, which are an additional risk factor. Thank you all very much.